Welcome to EULAR TV. Today, I am pleasure to introduce you Dr. Mrinalini Dey. She's an academic clinical fellow at the University of Liverpool. And during the next minutes, we'll be talking about her work on assessing the effects of increased body mass index on the response to TNF inhibitors in patients with established rheumatoid arthritis. This is the results from the Meteor Database. So, Dr. Dey, can you please give a brief overview of this study and what you found?
Yes, thank you, Sebastian. So yes, I'm an academic clinical fellow, and this is some work which I have done as part of that role in collaboration with Professor Landeve in Amsterdam. So just a bit of background. So high body mass index is increasingly prevalent among patients with rheumatoid arthritis. So in 2016, the World Health Organization estimated that approximately 40% of the world's population is either overweight or obese. And when you look at the population with rheumatoid arthritis, this actually increases to 60%. Rheumatoid arthritis, new presentations, it's increasingly prevalent that obesity is present at the first presentation of rheumatoid arthritis. And previous studies suggest that high BMI at diagnosis is associated with factors such as decreased quality of life and lower chance of achieving remission. However, it's not clear whether BMI influences the response to medications such as TNF inhibitors all to the same extent. So the aim of our study was to explore whether BMI is associated with response to TNF inhibitors, particularly looking at patients newly starting on these drugs, and also looking at each drug in turn and in groups such as the MAB TNF inhibitors. And we conducted the study in a large international cohort of rheumatoid arthritis patients with established disease. And our results showed that obesity is associated with a significantly decreased response to the MAB TNF inhibitors in particular. And we feel that this may be relevant going forward, particularly if we wish to use a personalized medicine approach to treating these patients. It would prove quite a simple and cost-effective way of doing this.
All right, those are very interesting results. And can you please tell us a little bit more about the Meteor Database?
Sure. So the Meteor Database is a large international database capturing real-world data of daily clinical practice in the management of patients with rheumatoid arthritis. Meteor itself actually stands for Measurement of Efficacy in the Treatment in the Era of Outcomes of Rheumatology. As of 2016, the database had captured data from more than 39,000 patients for over 200,000 visits in 32 different countries. And of course, that continues to grow. And the kind of data that they're capturing includes medication use, disease activity, and components of, for example, physical function. And that is at baseline visits and subsequent follow-up visits as well.
All right. And another thing I would like to know, and I would like you to explain that a little bit more, is can you describe a little bit more about the cohort included in this study?
Sure. So as I've said, we were using a cohort from the Meteor International Database. So we included patients who had established rheumatoid arthritis into this study who'd been recruited to the database between 2008 and 2013. The cohort that we used in this study had 731 patients from 11 countries in total. That may seem like a small number compared to the size of the database, but we have to remember that real-world data has many strengths, but one of the key limitations is that there may be disparities in comparability and consistency across practices. And so we had to ensure that all of the data we were using was comparable at the level at which we were studying. The data which were used, 82% of patients were female with a mean age of approximately 56 years. When we looked at stratifications by BMI, about 36% of patients were of normal BMI, another 36% were overweight, about 25% were obese, and the remaining members of the cohort were classed as underweight. Due to the low numbers of underweight patients, we actually exclude them from the analyses. We then looked at the number of patients who were on various drugs. So 264 patients were newly started on a biologic drug at their baseline visit, with 254 taking it after 6 months. And when you include the patients who were already on any biologic treatment at the start of the study, this came to around 400 patients. So that's really what the cohort looked like that we were studying. We then stratified the patients based on, the type of drug they'd been started on, and specifically we looked at people who'd been started on obviously TNF inhibitors, so adalimumab, infliximab, etanercept, and also golimumab. And then we looked at the people who were on MAB TNF inhibitors separately as well.
All right. So far we've been commenting on results based on TNF inhibitors use. But what about conventional synthetic DMARDs? Are there any information around that?
Sure. So actually, we looked at this in a previous study, which was the results were presented at the British Society for Rheumatology virtual conference this year. And crucially, we found that obese patients with established rheumatoid arthritis, again, were significantly less likely to achieve both DAS28 remission and a good EULAR response compared to those of normal BMI when treated with conventional synthetic DMARDs. And when we looked at this further, we found that combination conventional synthetic DMARD therapy in the overweight and obese populations was more likely to achieve more favorable outcomes than monotherapy. And when we looked at methotrexate in particular, we found that obese individuals of any disease stage were more likely to be on a higher dose of methotrexate compared to those of normal weight. So again, quite striking results in the population taking CSD-MARDs.
Well, certainly this information that you were providing can have an impact in clinical practice. And but can you, to wrap up, can you please comment briefly on what are the main implications that your findings will have in clinical practice?
Sure. So I think we're moving more towards trying to move towards a more personalized medicine approach in our patients. And I think this is really important because no two patients with rheumatoid arthritis are the same. And what we've shown is that looking at someone's body mass index may be a simple and cost-effective approach to providing personalized medicine, and tailoring their DMARD treatment in this way may lead to more favorable outcomes in this group. But I think these results, on a background of what we already know about body mass index in rheumatoid arthritis, it also impresses the importance of managing lifestyle and body mass index in these patients as well to achieve better outcomes overall.
The non-pharmacological management of the disease.
Yes, exactly. Yeah.
Well, Dr. Dey, those were very interesting results you have commented on, and I believe that in the years to come, there will be a lot more studies and a lot more evidence regarding the effect of body mass index, and also other forms to measure, for instance, body fat and other approaches to measure this the weight of the patients and its effects on the treatment, on the outcomes of rheumatoid arthritis and other rheumatic diseases. I believe we'll see a lot more studies in the years to come. So thank you for your time, and we hope you enjoyed this interview, and keep watching us at EULAR TV.